I never realized how disabling losing the hearing in the one ear would be.
This is Mike Rubenstein, a neurologist in Philadelphia.
Because literally, like I say, when I'm in a group, if I'm at a meeting, if I go to the American Academy of Neurology and I'm in a meeting and there's like a lot of conversation going on and somebody's talking to me, or I'm in a group of say 6 people and everybody's talking, I cannot make everything out. I hear only, a little bit of what everybody's saying. And that's been very, kind of eye-opening that it's that to that degree. And it makes you realize, when we think about like handicaps and we think about limitations that people have, it's been extremely limiting to me that I can't hear all that stuff. And so that's been, but the good news is when I'm sitting in a room with a patient, if I'm sitting in an exam room with a patient, I have absolutely no problem.
Hey podcast listeners, Jim Siegler here for Brainwaves, a podcast about neurology and medicine and all the fascinating science and history that come along with it. This week on the show, I got to speak with Dr. Mike Rubenstein, who's a neurologist at Penn, and he's been on the Brainwaves podcast before to talk about a couple of different interesting topics to him and to me. And this week, I asked Mike to share an unusual experience he had, an experience that has entirely reshaped his life, actually. A singular event which affects the way that he rides his bike, the way he drives on safari in Tanzania, and even the way that he interacts with his own patients. Anyway, I'll let Mike tell the story.
So I was feeling perfectly fine. I had no precursor. I didn't feel ill. I didn't feel anything at all.
This was 2 years ago, and Mike was at work at the
Children's Hospital of Philadelphia, where I work half a day a week, and I was seeing patients, and I actually had a visiting medical student from another school, and she had come down from Scranton to work with me, and so the two of us were sitting.
And they were just seeing patients together, the two of them, in a child neurology outpatient clinic. During one of the visits with a kid and the kid's mom, something just came over him.
And I had this incredible loud whooshing sound in my ears. Just a loud kind of whoosh.
Almost like a tone, he said.
And it lasted just a few moments before I suddenly realized that I was going to become incredibly ill. That was the last thing that I remember, and then I just became suddenly vertiginous and incredibly nauseated.
It was pretty sudden, pretty acute.
I felt like I was going to die. It was probably, the worst I'd ever felt in my life.
This sound in his ears, the sensation of nausea, the dizziness.
Everything was moving around me.
And the whole time, he's still in the room with the patient.
Long enough that I was able to click on the after visit summary to print.
Just to discharge the patient.
Discharge the patient. And I kind of remember myself kind of saying, okay, here's your after visit summary. I'll see you later. And they walked out of the room.
And right as Mike's patient left the room, he reached over to the med student and he said, "I'm experiencing vertigo and I'm about to throw up. Get me a trash can." Not, can you get a doctor? Can you?
No. Well, there was a doctor there. I was there. And I remember kind of lying there, still like everything was just going round in circles. And I felt like really nauseated. And I realized that if I moved at all, I would start vomiting. And I then started vomiting. And the medical student, I told her, I said, well, I'm having this acute vertigo attack. If you could just stay here for a few minutes. And so she stayed. And then I said, it may be better if you go out and tell one of the nurses what's happening, because we still had one more patient to see. So she went out to tell the nurses. They came in, saw me looking like, probably white as a ghost, and laying there vomiting. And they asked me what I wanted them to do. And I said, well, I'm just going to lay here for a few minutes and see if this just goes away.
So Dr. Rubenstein figures that he could just wait it out. Give it a few minutes, see if it gets better. He felt too ill to move at the time, which is why he didn't even think to go to the ED or anything. And the medical student was great. She waited with him for a few minutes, watching to see if he's going to get better. But he didn't get any better. So Mike calls a colleague of his, a neurologist also, and he explains the situation to his colleague.
And was wondering what you thought I should do. And he says, well, you're either having labyrinthitis or vestibular neuritis, or you're having a stroke. So I said, oh, so I guess I should probably do something about that.
So Mike went to the emergency department where he was, at the children's hospital.
So they came up with a wheelchair, a children's wheelchair that I could barely fit in. And I remember as soon as I got into the wheelchair, I started vomiting. So they had I had a basin with me, and they wheeled me through some corridors and through one of the wards at children's, and then down some elevator where I had no idea where I was. And I was just profusely diaphoretic. And they brought me to the CHOP emergency room,
where a pediatrician evaluates him.
And lays one eye, looks at me and just says, I think we need to send you next door
to see an adult ED provider at the hospital at the University of Pennsylvania.
They had to wheel me out on the street. So
in the dead heat of summer, it's 12 noon or something.
With my basin, vomiting in the same wheelchair.
And this is when I get to meet him, at the CT scanner at the University of Pennsylvania, when I was a senior resident on the stroke service at the time.
That's when. And I just remember you and Donna and Scott there. And I think there may have been one other person. There may have been a fellow, somebody else, but I can't remember. But you guys just started doing a stroke code on me.
Sure, yeah, the stroke team. So I have a lot of questions, mostly about feedback for me as now a more independent physician. Did I do well? Do you think I did good by you? But
I think we should probably keep that private.
But I do want to know, what is it like to experience an acute neurological problem that could have been life-threatening? Thankfully it wasn't, but could have been life-threatening, and then to be seen by a bunch of other trainees that you were teaching, and to come back into your own hospital system and to have an idea of what was going on, but not quite know.
Well, the good thing is most of it is a blur to me. In the emergency room, I just remember feeling just so incredibly ill and vomiting, and just I had absolutely no way of controlling my nausea and vomiting, but it was all a blur. And I kind of remember you guys examining me, and I just remember that I had my head down in the basin, and I remember you guys trying to look at my eyes, and I couldn't look up, because if I raised my head, I would just start vomiting more. But I'd have to say that I felt incredibly confident of the people who were taking care of me. I had absolutely no qualms. And it was kind of different. I had absolutely no control of the situation. So I was in your hands, basically, because there was nothing that I couldn't say well, are you sure you want to do that? Are you sure you want to do this? Or should we check this? Or should we check that? I couldn't think of anything. So really, I was in your hands.
At this point, Mike said it was impossible to even imagine supervising a team of residents and physicians in this emergency situation. He was simply too ill to focus. So he just let us do our job. And presenting with acute vestibular syndrome, especially for an older patient, sorry Mike, you are a bit on the older side, you have to rule out a posterior circulation stroke. Alright, up until now we focused on this being kind of an interesting story about a doctor who's trained in neurology, who's experiencing acute neurologic illness, kind of like what we did back in the episode on Lyme disease with Dr. Quinn. But for the remainder of this show today, we're going to talk about some of the clinical pearls of Mike's story, as if it were a clinical case that we discuss on Brainwaves. An older patient who presents with acute vestibular syndrome. So first of all, what is acute vestibular syndrome? I would say that it's the sudden onset of persistent nausea, vomiting, gait unsteadiness, and intolerance to head motion. Now, I didn't say vertigo because I don't really like that word sometimes. People can have subjective vertigo all the time, and it's really difficult for me to distinguish vertigo from dizziness, so I use the term head motion intolerance. And Mike had these symptoms. He got a CAT scan on the off chance that his symptoms could have been related to a hemorrhage of the posterior fossa or a stroke. On the CAT scan, there was no blood, so we followed this up with a CT angiogram, which showed no occlusion of any of his posterior circulation vessels. So then he got an MRI, which confirmed that there was no ischemia. But as you know, MRIs are poorly sensitive in the posterior circulation. The DWI sequence can miss 20% of posterior circulation infarcts, maybe even 50% of infarcts in the medulla. So Mike had all this workup for his acute vertigo.
And I should say that one of the things that was discovered when I was in the emergency room, in addition to the vomiting and the vertigo, was that I also couldn't hear out of my left ear.
Now, this is an interesting clue, because sudden unilateral hearing loss is a very focal deficit. In vascular neurology, it should make you think of a stroke to the body of the cochlea. And fun fact of the day, this is typically due to an occlusion of the labyrinthine branch of AICA, the anterior inferior cerebellar artery, or sometimes off the basilar. Rarely, about 10% of the time, you can see cochlea involvement in a pica stroke, but mostly I think about AICA. And when you MRI these folks, as you probably know, the distribution of the infarct is going to involve the middle cerebellar peduncle and the anterior and inferior portion of the cerebellar vermis, just as the name suggests. But let's consider the non-vascular causes of acute vestibular syndrome when it presents with a unilateral hearing loss. Acute vestibular neuritis is one condition, and this can be distinguished by the characteristic preservation of hearing. I'll say that again. With vestibular neuritis, or inflammation of the 8th cranial nerve, hearing is often intact. Labyrinthitis, on the other hand, is nearly clinically identical to vestibular neuritis, with the exception of it also has unilateral hearing loss, which is ultimately what Mike had.
So the diagnosis is labyrinthitis, and the reason it's labyrinthitis is because I had involvement of hearing in addition to just the vestibular process.
Both processes, vestibular neuritis and labyrinthitis, they can both be post-infectious, usually viral, and often patients won't remember feeling sick recently, so I wouldn't really rely on this bit of historical information. In each of these syndromes, AICA stroke, vestibular neuritis, and labyrinthitis, they'll present with a sudden onset of nausea and sensation of vertigo or head motion intolerance, dizziness. If you see somebody who comes in with a combination of truncal ataxia, dysarthria, facial weakness on the same side, or numbness, sometimes even ipsilateral limb dysmetria, that should make you think of a stroke to the AICA territory. And if you see nystagmus, which you'll see in up to 2/3 of patients, it's often present in primary gaze. It's horizontal and it beats away from the affected side. And of course, in a posterior circulation stroke, you might even see a skew deviation, or a misalignment of the eyes that's not attributable to a cranial neuropathy. This usually indicates brainstem dysfunction, and that's why we include it in the HINTS assessment. And let's quickly review HINTS, because it's an important subject. I know that you've heard of it, and you probably know it very well, especially if you're a neurology resident, because we do it all the time in the emergency room. But bear with me. So HINTS, H-I-N-T-S, it was designed by some investigators to be a highly specific bedside assessment for stroke. And if any one of the abnormalities were present, any of those abnormalities, meaning a patient could have a normal horizontal head impulse test, or they could have a skew deviation, or they had a central appearing pattern of nystagmus, any one of these, then the pattern was considered dangerous, and the patient almost always had a stroke. At least that's what they reported in their study. But with that, I'll give the caveat that the HINTS profile is not a perfect bedside tool. The findings have been difficult to replicate from the initial study, and I don't know how many patients that I've seen who come in with a benign dizziness, and they have a normal response to horizontal head impulse testing. Doesn't mean they've had a brainstem stroke, but normally you should think of a horizontal head impulse as being associated with a brainstem disease. And the nystagmus can also be confusing, so I thought that we should revisit a prior show that we did on the localization of various types of nystagmus, starting with gaze-evoked nystagmus.
This type of nystagmus is purely horizontal without much of a rotary component.
This is Dr. Ali Hamidani, who's now a neuro-ophthalmologist here at Penn, and he helped produce a previous show on this topic.
It is direction changing, meaning that it's left beating in left gaze, but right beating in right gaze. And it typically does not persist in up gaze. You can have upbeat nystagmus that accompanies gaze-evoked nystagmus, but that's technically a little bit different.
And this type of nystagmus, a lateral beating eccentric nystagmus that changes based on one's gaze, it's one of the nystagmus types that we see in central lesions, along with upbeating or downbeating nystagmus. Next, let's move on to the vestibular nystagmus.
So vestibular nystagmus is by definition unidirectional,
associated with the unilateral vestibular nerve lesion.
And it beats in that direction regardless of the direction of gaze. So, for example, if someone had right vestibular neuritis, you would expect to see left beating nystagmus that's always left beating no matter which direction of gaze they look. Usually has a mixed horizontal and rotary component, and it may be present in primary gaze, and an up and down gaze would be persistent, but still pretty minimal. In addition, it obeys something called Alexander's law. What that means is that the frequency and amplitude of the nystagmus changes based on the direction of gaze, and it specifically changes in a way where it's more prominent when one looks away from the side of the vestibular lesion.
Meaning, as one looks in the direction to which the eyes are beating, the nystagmus will become more prominent.
In vestibular neuritis, the thought is that all of the semicircular canals are inflamed more or less equally, and because the anterior and posterior semicircular canals sort of cancel each other out in terms of their rotational effect, the rotary effect that you see comes mostly from the horizontal semicircular canal.
And this kind of nystagmus is exactly what we saw in Mike when he came to the ED. This kind of a rotary right-beating nystagmus that obeys Alexander's law, and it worsened in right gaze. Exactly like the kind of nystagmus that you should see in a peripheral lesion.
I caution the use of the term central and peripheral, though, because you can imagine that if you had a lesion right where the fibers of the 8th cranial nerve enter the medulla, or even a little bit more proximally at the level of the vestibular nuclei, not much has changed in terms of the anatomy, and so you'd expect the same pattern of nystagmus, but now you're in the central nervous system.
Okay, so Mike had this type of a torsional nystagmus, and he was given a diagnosis of acute labyrinthitis. He was discharged home.
It may have been like 2 days later or something. I called a friend in ENT who does the neurootology, and I said, I had this episode. I'm lying here at home, and I'm just wondering, is there anything that I should be doing? And he says, yeah, you should be coming in here, and we should be putting some steroids in your ear.
Steroids in his ear.
It's an injection through the eardrum into the inner ear.
I imagine that's not pleasant.
No, it wasn't. So the first ENT I saw wasn't the person I had spoken to on the phone who's a friend, but it was another ENT. And so he actually numbed up my ear canal and the eardrum initially with
topical
some
lidocaine.
Topical, yeah. And so he did it. And actually my friend, who's also a doctor who had brought me there, watched the whole thing on the computer screen because they have a little television monitor there and you could see.
But this didn't really help. On a population level, intratympanic corticosteroid injections are generally pretty well tolerated in patients who have this diagnosis of sudden sensory neural hearing loss. And I saw at least one randomized clinical trial that proved this on my review of the literature, but I'm not an expert in this.
Whether it helped some of the vestibular symptoms, it's possible that that the vertigo, which lasted about a week or so, that improved dramatically, but the hearing loss never improved.
Before you recovered, when I went to visit you, things weren't so hunky-dory. You were pretty debilitated.
I couldn't sit up.
You were bedbound. I mean,
I could not sit up.
There were also other complications.
So the other complication, and partly I think I'm really the only one to blame for this, is that I went home, and so I laid on the couch feeling nauseated and vomiting, and I wasn't drinking enough. And so I went back to work on Wednesday, and I noticed that I had this kind of cramp in my leg.
It was a DVT.
There's no way I can have a DVT.
Yeah, there was.
But I had a DVT.
Yep. We doctors make the worst patients. Oh, God. Okay.
So I ended up getting introduced to Mr. Lovenox.
Yeah. So not a lot of DVT prophylaxis with vestibular labyrinthitis.
Yeah, so I basically got put on Lovenox for 10 days, learned how to inject myself, and then went on to Pradaxa.
But not just Lovenox and then Pradaxa. He continued to have this persistent post-thrombotic syndrome with pain in his leg, muscle cramping and swelling, and he wanted to do something more than just prevent another clot, which is basically all these medicines do. So he found an interventional radiologist who would infuse a continuous amount of TPA into the clot.
And actually lyse the DVT.
And then the surgeon attempted to mechanically remove it.
Well, this is something that is probably not quite ready for prime time.
Which again, all this was entirely the consequence of his vestibular labyrinthitis and feeling unable to get around for that first week.
And then they went in for the mechanical, and he was able to clear a little bit, but it was pretty much all cement and really couldn't get done. So it wasn't the outcome that he had hoped for.
Can I see your leg?
You want to see my leg? Yeah, so you can see my leg. So I get.
But that wasn't it. The labyrinthitis wasn't just going to stop there.
So my hearing has never recovered, and I ended up with about maybe 10% hearing in that ear.
2 years later, things still sound almost inaudible from Mike's bad ear, and there's nothing that can be done to fix it. Hearing aids won't work because there's just not enough of a functioning inner ear apparatus to transduce that signal.
I can't really hear anything. If I go to scratch my right ear, my good ear, if I go to scratch my right ear and I put my finger in my ear, I can't hear a thing. It's silent. Sometimes that's good, actually, if you don't want to hear people.
When you're staffing junior residents
exactly.
in clinic. Yeah.
When I'm sleeping, if I roll over and with my right ear down in the pillow, it's completely silent. I can't hear anything. So basically, I've never recovered any of the hearing on that side, which has been probably the main problem and the most disabling thing of all this.
Mm-hmm. Loss of hearing like this is disabling. I mean, it does sound kind of irritating, I guess, if you're having a conversation with somebody at dinner and you can't hear them when they're on your bad side. But imagine being a cyclist, which Mike is, and having to navigate through the traffic of Philadelphia without running into cars or other cyclists. There's an entire half of his world out there which is unsafe to him.
You completely lose all localization.
Car over here, trolley over there, makes no difference. Whatever Mike hears now could be in front of him, it could be behind him, it could be moving closer to him or moving further away, and there's no way he's going to tell.
I would have no idea which direction it's coming from. So,
to make matters more complicated, it's not that Mike's hearing loss means one ear is silent to him. There is a sound, but it's not a sound coming from his acoustic environment.
I have a continuous tone in my ear. So if I reproduce the tone, so if I sit here and if I want to shut the tone off, I can go shh, and I can mimic the tone myself, and then that essentially balances it, and I don't hear it any longer. But that's the only way it can go away. It's a continuous noise that I have in my left ear.
Okay, even when you're talking, when you're hearing people,
when I'm talking, sitting here talking right now, I have this it's almost like I wish there was some way of putting a microphone up to my ear so that somebody else could hear it. Because it sounds like you should be able to hear it.
Yeah, I mean, it sounds like it's a life-changing experience that I hope no one else has
Not
to
that
experience.
You want to go through.
Yeah, no,
yeah.
And from an outsider's perspective and seeing it kind of happen, and in the acute setting, and then also as you've kind of gone through this recovery phase, both at work and at home, and being able to go out with you, and you coming back and joining me on the podcast this whole time, you're still contributing to society. You're doing such a great job with all this, but it's very, very much disabling for the reasons you said it is.
Right. And it's also one of those things that it's not something you can see. It's not like I have I have a hemiparesis or walking with a walker. It's not visible to anybody. So
yeah. Now it's 2018, 2 years after Mike's bout of acute labyrinthitis. He's still deaf in that one ear, still can't localize sound well at all. A lot of patients who have the kind of condition that Mike had, they experience the same kind of recovery that Mike does.
I've had absolutely no continued vertigo, no vestibular dysfunction. I'm able to ski. I'm able to, scuba dive. I'm able to do all those things.
Resolving vertigo and balance gets better over days or weeks. But the hearing aspect, the recovery of hearing is extremely variable. Most patients do regain most of their hearing, and some people even normalize. But for whatever reason, some people never get their hearing back. I think there's a lot to take away from Mike's story as a clinical case. Knowing how to evaluate for acute vestibular syndrome, being able to recognize the patterns of nystagmus that can be concerning or are central in origin, like gaze-evoked nystagmus or vertical nystagmus, knowing where to localize the lesion when it's the brainstem and you see more long track signs and you see facial weakness, ataxia, or if there's hearing involved and you would suspect labyrinthitis. And treatment, which we didn't really get into, but it consists of oral or intravenous steroids for a short course, usually with antiemetics. and then trying to avoid long-term antihistamines like meclizine, which can cause some tolerance and even withdrawal. Mike also received intratympanic corticosteroids, which could be a very useful alternative to systemic corticosteroids, especially for your diabetics and those who don't tolerate steroids well. I don't know. I think I learned a lot in seeing Mike in the ED that day and working with him over the past couple of years as he's been kind of coping with this process. It definitely didn't seem easy to him, but I think we're all grateful that he ended up having a peripheral problem and not a stroke. And that wraps it up for the program this week. Thank you so much for tuning into the show. If you're new to Brainwaves, definitely take a look at what we've got in the archive on iTunes, Google Play, Stitcher, or wherever you get your podcasts. This is the 119th formal episode that we've done so far, so chances are you're going to find something that you like. And if you haven't rated the show, please do so. It really bumps up the show in the search engines. And with that, I'll say the Brainwaves podcast is produced out of Studio 3 in Philadelphia, Pennsylvania. I'm Jim Siegler, the senior producer. Music for our program this week was courtesy of Axel Tree, Chris Zabriskie, Heftone Banjo Orchestra, and Lee Rosevear. Sound effects by Daniel Simeon and Mike Koenig. Special thanks to Dr. Michael Rubenstein for sharing his incredible and personal story with us on the program this week. I'm Jim Siegler for Brainwaves, and I'll talk to you again soon.